Good morning to all. Today I like to discuss one very much important topics, that is arthritis. Arthritis, it may be juvenile idiopathic arthritis, may be osteoarthritis. In adult medicine it is called osteoarthritis, but in pediatric age group it is called juvenile idiopathic arthritis. You should be knows. It is common rheumatic disease of the children and one of the most important chronic illness of the childhood. Remember this one. Now, how to nomenclature is did. Before this time, before 1995, the childhood arthritis is called juvenile rheumatoid arthritis by American College of Rheumatology. But in 1995, again this nomenclature changes to juvenile idiopathic arthritis by International League Association of Rheumatology. That's tell the changes to nomenclature JRA to juvenile idiopathic arthritis. Another classification was European League Against Rheumatism called juvenile chronic arthritis, but it is not accepted by the World Health Organization. But juvenile idiopathic arthritis is accepted by the World Health Organization. Remember this one. First of all, you should know the how the patient present to you. Patient is arthritis. Patient present to you by arthritis. Arthritis means as intra-articular swelling, presence of two or more of the following criteria. What are the criteria? Limitation. Just look to me. Limitation range of movement. Limitation of the range of motion. Tender and faint on motion. And increase the heart, increase the heat, or increase the temperature, local temperature increase. This is called arthritis. You should be know this one. What is arthritis? I told you. Now, what the pathophysiology? What the pathophysiology of the arthritis? You should know this one. You should know the pathophysiology of the arthritis. Pathophysiology of arthritis means it is a autoimmune disease associated with alteration of the both humoral and cell-mediated immunity. Remember this. T cell play vital role in this disease to release the cytokine. T cell is the most culprit lymphocyte. It releases the cytokine for the inflammation. Then after release of cytokine, what will happen? There is a activation of the inflammatory cell like monocyte, lymphocyte, plasma cell, and also there is activation of the complement system. Then what will happen? There will be abiotic causes of inflammatory synovitis. There will be inflammatory synovitis. And which causes villous hypertrophy, hyperplasia, hyperemia, and edema of the synovial tissue, and activation of the inflammatory cells like mononuclear cell, plasma cell, lymphocyte like this. Abnormal uncontrolled disease lead to formation of the penis, which causes progressive erosion of the articular cartilage and contagious bone. Remember this. This is very much important. Pathogenesis. I told to you. Next you go for about the GIA, juvenile idiopathic arthritis. Classification of the juvenile idiopathic arthritis. First all you look oligoarticular types of GIA. It is about 40 to 50%. It is again two types: persistent oligoarthritis and another is extended oligoarthritis. Oligoarthritis means less than 4 joint involvement. Persistent oligoarthritis means there is only the 4 joint is involved throughout the disease process. But extended oligoarthritis, it is for more than 4 joint is involved during the last 6 months. Next one is polyarticular arthritis or polyarticular GIA. It is about 25 to 35%. It has two types. One is rheumatoid factor positive types, another one is rheumatoid factor negative types. Next, number 3 is systemic onset GIA. Systemic onset GIA means it is the arthritis with quotidian fever at least for 3 days and have 2 or more of the following criteria. What is the criteria? Evanescent erythropoietic rash, Then there is a generalized lymphadenopathy, hepatosplenomegaly, and serositis. Serositis being pleural effusion, pericardial effusion, and pericarditis. Next one is psoriatic arthritis. Very much important one is psoriatic arthritis. It is about 5 to 10%. Arthritis or psoriasis, at least two of the following. What is it? Dactylitis and nail pitting and auriculosis. Psoriasis of the first degree cousin or first degree relatives. Remember this. Next one is enthesitis related arthritis. It is about 5 to 10%. Arthritis with enthesitis with at least two of the following criteria. What are the following criteria? Look, history of tenderness of the sacroiliac joint and lumbosacral vein, presence of HLA-B27 antigen, and onset of arthritis in a male child more than 6 years of old, acute anterior uveitis, and history of ankylosing spondylitis. This is the number. Last one is undifferentiated arthritis. You should know this is all about. Now the how the diagnosis is confirmed. How the diagnosis is confirmed. Diagnosis is confirmed by the clinical diagnosis. This is clinical diagnosis, but laboratory investigation should be done for confirmation and differential diagnosis. For differential diagnosis and confirmation of the disease, first of all, there is a complete blood count. Complete blood count, OC reactive 14. What will happen there? WBC count will increase, platelet will be increase serum ferritin, and increase C reactive 14. Urine protein microscopy examination to see the proteinuria and hematuria to exclude the SLE, acute glomerulonephritis, or Henschkel purpura like this. Next, antinuclear antibody is should be done for oligoarticular types of GI. Remember this. Now is last one. Last one is about remote. Next one is next one of investigation is remote factor. Remote factor. You should investigate remote factor for polyarticular types of GIA and systemic onset GIA. Remember this. And anti-CCP antibody should be done. Good serological marker for early diagnosis of the GIA. It is highly specific, more than 98% is highly specific. And differentiate other types of arthritis. Next one is imaging. What is the imaging? Except the knee joint, except the joint, to see the soft tissue swelling, bony density, joint erosion, joint space, and deformity. You should know. Then last one you follow MRI. What do in MRI? MRI to see the structure of the cartilage and bones. Last one, ultrasonography. One ultrasonography should be done to see the intra-articular fluid. Next one is synovial fluid analysis. Synovial fluid analysis, synovial biopsy to see the tubercular arthritis. You should remember this one. Next, arthroscopy done. Arthroscopy to see the fallus formation. Now how the treatment is given. What the treatment? How the treatment is given? Treatment is multidisciplinary approach. Treatment is multidisciplinary approach, included pediatric rheumatologist, pediatrician, then physiotherapist, occupational therapist, ophthalmologist, orthopedic surgeon, then nurse, then dentist, then social worker, then child psychologist. You should include a vital role to the treatment of this baby. You should remember this is a multidisciplinary approach. And now go for a therapeutic modality. What a therapeutic modality means? First term, you given the NSAIDs. NSAIDs means ibuprofen, naproxen, infliximab. These are the very safe drug for the children. And next one is DMRD. DMRD, look, DMRD. DMRD, what DMRD you go there? First all given there, methotrexate, then sulfasalazine, then sulfasalazine. Next one, hydroxychloroquine. Very good. Next we go DMRD, then given the biological agent. Biological agent should be given to reduce the production of the cytokine. Biological agent should be given to protection of the cytokine release. What are the biological agent? What a biological agent should be given? That is TNF alpha, interleukin 1, interleukin C, and anti-CD20 cytokine should be prevented by the biological agent. First of all, TNF alpha. TNF alpha is very much important one. TNF alpha is prevented by etanercept. Etanercept, then infliximab, then adalimumab. It is very much important for polyarticular GI and system onset GI. Remember this. Then interleukin 1 preventers is anakinra. Next one is interleukin 6 preventers. Antagonist tocilizumab should be given. It is very much important for polyarticular GI and system onset GI. Next one is anti-CD20 antagonist rituximab should be given. Final treatment is autologous stem cell transplantation. Then treatment of the uveitis by the local steroid. Then treatment of the osteoporosis by calcium and vitamin D supplementation. Now what the parents counseling? Parents counseling about the natural history of the disease and its outcome. It is common chronic illness of the childhood, waxing and waning nature of the disease. Oligoarticular types of GIA group prognosis is very good, but polyarticular GIA and system onset GIA prognosis is very much poor performance. Remember this. Now what are the complications of the GIA? What are the complications? What are the complications of the GIA? Right to report. Joint contracture with and ankylosing with atrophy of the adjacent muscle, anemia, pericarditis, myocarditis, glomerulonephritis, chronic enteritis, growth failure. Thank you very much. Thank you very much for patient hearing.